evening, everyone. Thank you, the organizing team, Dr. Varun Tyagi and IASMPMM founders, Dr. Ajay and Dr. Nair, for giving me this opportunity. I'm Dr. Saurabh, practicing urologist, enterologist, HOD at Primus Hospital and RG Stone Hospitals, Delhi. Today, I'll be speaking on the issue prostate health and the sexual wellness. See, here prostate health and the sexual wellness, I am not here to tell you about what is the prostate and what it functions and how it works. We all know a 22-gram walnut size mainly causing the ejaculations and all. We have to see like how a patient, mainly an elderly male who is coming to you with his problems, like how it behaves and how you have to deal with that. So regarding the prostate, we'll be dealing with the 4 things. The first thing, whenever a person is coming, he always asks, whenever a male gentleman is coming, he always asks, sir, I am ejaculating so many times. Is it a normal for me? Or like, what do you have to say? You say, yeah, it's normal. All the masturbation is normal. You have to continue that thing. Then the question comes in the mind that whether we know this is no harm in the masturbations all, whether it's a beneficial or not. Whenever I was thinking, and not me, only me, we all read that whenever there's more increase in the ejaculatory frequency, this has a preventive role in CA prostate or a BPH. But it was disheartening for me and also most of you, when I go with all the journals and all the research papers, we got to know that increased frequency of sexual activity has no beneficial role in a CA prostate or a BPH. All the papers say there is a marginally 0.1% decrease in the CA prostate, which is not, p-value was not significant. So there is no increase in no beneficial effect of ejaculatory frequency on the CA prostate and BPH. Now the next point which comes to us is the whenever the patient is coming with a painful ejaculation, we think it's a prostatitis and we deal with that. It has no effect on erections. Only the problem which comes in the prostatitis is it causes a painful ejaculation, and we deal with the antibiotics and all, and for the less pain we tell them to mainly increase the ejaculatory frequencies to deal with this problem. Third thing coming with the prostate is the use of 5-alpha reductase inhibitors, which all the urologists give. 5-alpha reductase inhibitors are known to cause the erectile dysfunction. They cause the erectile dysfunction by decreasing dihydrotestosterone, DHT. DHT receptors are there. The DHT decreases, which causes decreased libido and erectile dysfunction problems. This DHT is the main troublesome problem, but we can't do with it. We have, for the increase in the prostate health in aging male, we have to give with the finasteride or the dutasteride tablets. We can omit this dutasteride, finasteride whenever based on the prostate size. So for that you have to refer to the urologist, nearby urologist or any clinician to decide upon that. Now comes the main part. Whenever an aging male, he is coming you with the urinary tract symptoms and a decreased sexual frequencies. You have to think it in the 2 things. Whether I am dealing only with the BPH or is it something else, or is it like a BPH with a andropause. BPH means benign prostatic hyperplasia, which I am not dealing with because this is not the podium for BPH. We have to deal with the sexual side effects. So we have to think it whether it is only a BPH or it's something else. Is it a BPH plus a andropause? What is an andropause? Andropause is mainly a gradual but a progressive decline in serum testosterone which goes with the aging. Sometimes it's referred to as a male menopause, but it's not simply a male menopause, because men are more dependent on the testosterone than women. This decline is slow, not sudden, and the symptoms are subtle. Culturally, medically, andropause is either brushed off as a midlife crisis or we ignore. Patient ignores, the clinician ignores. We have to see whether our patient whether actually he is going on with this andropause or not. It comes with many synonyms. We don't have to do with it, Adam, like androgen deficiencies, aging male climacteric menopause. We have to see why it is happening in our patient. This andropause is related in part to fertility needs and the virility. However, unlike women, men are constantly producing new sperms throughout their adult lives. With advancing age, this need of sperms decreases. That's why this andropause is happening. What makes this andropause complicated is the relationship of the testosterone which is going on in the blood, whether this is the free testosterone or total testosterone. We can see here that in our blood, the circulating part of the testosterone which is roaming is only 2% which is free. This is very important to understand, like when we ask for the testosterone test. This 40 to 60% is a weak binding which is binding to albumin. This is bioavailable testosterone. 60% of the testosterone which is a strong binding to the SHBG, stress hormone binding globulin. So this is these three things considered to be total testosterone which we order. Generally that we should not. And the bioavailable testosterone is only this part. What the physiological effects of the testosterone? From top to down, in the CNS part, it goes on with the well-being, memory. It makes the voice husky. We all know kidneys. It increases the erythropoietin, increases size and secretion of the prostate, and the development of the genitals. It increases the bone mineral density, muscle mass. It increases, and the adipose tissue. Now, when the patient is coming, we have to see why this is happening. There is a reduction in the size and the weight of the testes. This is because of that increased level of stress or the genetic disorders, or whether my patient is going on with other problems like obesity, malnutrition, physical stress he is having, other chronic illnesses we have to see, or the medications I think he is taking, like some patients are taking the antidepressants, opiates, estrogen and the anti-estrogens. We have to see what all he is getting, what all he is facing. The patient, might complain of you with the reduced energy, fatigue, decreased libido, the erectile dysfunctions, decrease in strength and the lean body mass, and the hot flushes, sweating, insomnia. These can be the symptoms for that. Or he may be having irritable mood, lack of motivation, low mental energy, depression, low self-esteem. When all these things we consider, we should think of the andropause in our aging male. Aging male means the patient who is more than 45 to 50 years. How do you diagnose this thing? This can be with the signs and the symptoms. Secondly, with the measurement of the testosterone values. These testosterone values, the point is, these markers should be reproducibly, there should be a low measurement of testosterone. Reproducibly means, like, it's not about a single value you have to see. You have to consider it repeating that testosterone value. And if it consistently comes to be a low, then you can think of this andropause. You have to measure the testosterone mainly in the morning from 7 to 10 a.m. Okay, and this variation in the younger men, there is variation in the laboratory references also. Each laboratory should develop its own reference range and you have to go with that. Normally we take this testosterone values from 300 to 1000. This should be nanogram per deciliter. If it is more than 350, then this is not a case of the andropause. This is normal. If this value comes less than 250, yeah, then definitely he is you have to investigate why this is happening. In the gray zone is 250 to 350. This is the slide which you have to go through that, like whether if you are dealing with the signs and symptoms, what I told you, all the low fatigue, mood and all the low self-esteem, you have to think of whether yes, if it isn't, then measure the morning serum testosterone values. If no, then no testosterone replacement therapy. Morning measure. If it is more than 350, then there is no treatment. If less than 250, yeah, consider it is repeating the sample again after 3 days. Then if it is consistently coming with less than 250, then think of the TRT. TRT means testosterone replacement therapy. Or if the morning serum testosterone is less than 250, in the gray zone of 250 to 350, then you have to go for a free or a bioavailable testosterone. This free or bioavailable testosterone is normal, then this falsely these testosterone values are in the gray zone, or if it is consistently coming to the low, then go with the TRT treatment. If in case of any doubt, you can ask me, because this was the most important things which we are dealing with, because we generally, the clinicians, what they do, they with the single values they start with the TRT treatment. This is the same, the repetition of the slide, just to show you why we are measuring the morning samples and why we are considering free testosterone as more important. Now coming to the management of this part. The most common treatment options includes the healthy lifestyle. Healthy lifestyle choices, those who are mainly obese. Eat a healthy diet, regular exercises, get a good sleep, reduce your stress. Refer to the psychiatrist who may prescribe the antidepressants and the behavioral therapy if you are experiencing the depression in the patient. Hormonal replacement therapy you have to consider if none of these are working. I am not going with the TRT treatment in the what now the patients, what they are thinking, they will be coming to you, sir, can we take all this Shilajit and all, because there are no scientifically proven treatment for this testosterone in the Shilajit and all. So I am not dealing with that. I am just considering what all we have to prescribe and what our books say. Symptomatic endometriosis is controlled by the testosterone supplementation. It can be, it's in the 4 forms: oral, injectable, pellet, or the local dermal applications. Coming to the oral part, the oral testosterone is metabolized very rapidly by the liver. Therefore, it's a liver hepatotoxics. All these oral 17 alkylatyl forms are hepatotoxics, and we don't prescribe this. The buccal part comes in the pellet. You have to apply it the gum at 12-hourly interval. They swell to the gum. It's very irritable. So generally here in India we also don't prescribe these. Generally we prescribe by the dermal applications, or we go with the injectables. In the injectable parts, this testosterone enanthate or the saponate are administered at 200 mg twice weekly or 100 mg weekly. Bi-weekly, 200 mg bi-weekly or 100 mg in weekly. Serum testosterone levels rose to the supraphysiological levels from day 1 to 3 after the injections. We have to monitor. We'll consider the monitoring part. I'll deal it with the later. You have to think of the fluctuations in the serum testosterone levels with these injectable parts, because this fluctuation can cause variations in the mood, the acne, and the skin oiliness of the skin. So you have to time counsel this patient about this thing. Second thing in the injectable part is the testosterone undecanoate. These intramuscular injections, they were earlier available only in the China. Now they are readily marketed in the US also. They administered at 1 gram in a castor oil every 12 weeks. 3 monthly depot injections they are. Testosterone gel, what I was talking about, the dermal applications are the testosterone gels. These 5 gram or 2.5 gram gels are delivering approximately 5 mg testosterone. Usual dose is 5 gram per day. Minimal skin irritability, no skin patches. The best part is the flexing or flexibility of the dosing, and they generally gives us steady state testosterone levels in our body. Potential problem of transfer of testosterone is prevented by clothing. The problem is only with the clothing, that whether they get rubbed or not, or taking a bath. So you have to apply it after taking a bath. This is a known move. With these testosterone replacement therapies or so-called TRTs, the beneficial effect we have seen. We have to think of what are the possible side effects, then only we can prescribe all these TRTs. The major side effects are the sleep apnea, stimulation of the growth of the prostate system, increased risk of heart attack and stroke, and the formation of blood clots in the veins. Conditions in which we have to think of when we have to give, but we should also know when we don't have to prescribe these TRTs. They have very severe adverse outcomes, so we don't have to prescribe in the cases of these hormone dependent cancers like prostate cancers and the breast cancers. Take the history very well, that whether the patient is having these type of cancers or not. Or moderate to high risk of the other outcomes, like when there is unexplained PSA elevation, erythrocytosis, when the patient is coming after the TRT treatment that, sir, I am facing the urinary disturbances, or having some problem in the heart like angina and all. So always monitor the testosterone therapy by clinical response or the adverse effects 3 monthly. After 3 months, check the testosterone values, then check the testosterone levels, check the hematocrits. Hematocrits CBC you have to do at the baseline, then 3 monthly, then annually. Bone mineral density you have to check yearly or bi-yearly, like in 2 men with the osteoporosis, because increases osteoporosis, decreases the osteoporosis, but it increases the bone mineral density by erythropoiesis. Another point in the monitoring is check with the digital rectal examinations, refer to the urologist whenever you find any prostatic nodule and increase in the PSA elevations. PSA like more than 4 gram, refer him immediately to the nearby urologist. Abnormal DRE, increase in the IPS. IPSS is what we urologists take the score, symptom score whenever any patient comes for the urinary disturbances. Just for all other clinicians, just you have to ask her whether this urinary symptoms are deteriorating or not. It may be stated that the male andropause does exist. It affects the men over 40 years of age. We have to think that whenever any aging male is coming with a prostate problem, yes, the andropause can be the cause of this problem. Early diagnosis and the hormonal replacement therapy can improve these symptoms. These TRTs must be always administered only to a very responsible physicians by responsible clinicians under strict guidance of the case selection, and they're managing the adverse effects. Thank you. If any questions are there, you can ask them.
Okay. Thank you so much.
Thanks,
Just be there on the stage. Yeah. I request our chairperson to facilitate. Dr. Saurabh. Thank you so much.
पीछे एक बार लाइन टिम आ रहा था बहुत